It's a great honor for me to introduce my teacher, Professor Yusuf Usus, who's a well-known figure in Jordan, one of the founders of cardiology in Jordan. He will be talking about congestive heart failure and update.
Definition. Heart failure is a complex clinical syndrome in which patients have typical symptoms: dyspnea, fatigue, we are all know, fluid retention, signs of raised durable venous pressure, pulmonary crackles, resulting from an abnormality of cardiac structure or function. Some patients present without signs or symptoms of volume overload, so hence the term heart failure is preferred over congestive heart failure. I want to stress this fact that there is no single diagnostic test for heart failure. It's largely a clinical diagnosis based on careful history and physical examination. Epidemiology. Heart failure has been termed the new epidemic of the cardiovascular disease of the 21st century. Lifetime risk of developing heart failure is 20% for Americans above the age of 40, with 650,000 new cases diagnosed annually. Heart failure is a disease of age. The incidence increases with age. Between 65 and 69 years of age, 20 per thousand Americans develop incidence of heart failure. Above the age of 80, it goes up to 80 per thousand. And 5.1 million persons in the US have manifest heart failure. The annual number of deaths approaches 200,000, and heart failure is the leading diagnosis at hospital discharges in patients above the age of 65. Heart failure, that's the leading diagnosis in hospital discharge. In patients younger than 65 years, new onset heart failure is often associated with male gender, ischemic heart disease, and the reduced ejection fraction. Diagnosis, we have two types of heart failure. Heart failure with the reduced ejection fraction, which is, we used to call it systolic heart failure. Heart failure with preserved ejection fraction, diastolic heart failure. Recently they made it called HFpEF. Symptoms and signs are typical in both types, except that in the systolic heart failure, the ejection fraction is reduced, while in the heart failure with preserved ejection fraction, normal ejection fraction or mildly reduced, and left ventricle is not structural heart disease, as left ventricular hypertrophy, left atrial enlargement. What are the symptoms of congestive heart failure? None. Maybe stage 1 and stage 2, none. Truly asymptomatic. Or asymptomatic because of sedentary lifestyle. شو عندك حال ما بكن ماشي عايش متعايش معه لذلك لا يشكو من شيء. Dyspnea on exertion, orthopnea, and PLDs, paroxysmal nocturnal dyspnea, fatigue, decreased exercise tolerance, تعبان ما في حيل, ankle edema, abdominal pain and distension, palpitation, syncope or pre-syncope, and embolic events. These are mainly the symptoms of congestive heart failure. What are the stages? This is the American College of Medical Heart stages of heart failure. We have stage A, B, C, and D. A, the patient is at risk of heart failure, but without structural heart disease or signs of heart failure. For example, it's hypertensive, asymptomatic coronary disease, diabetic, obese, family history of cardiomyopathy, is eligible for heart failure, but still in stage A. Stage B, he has structural heart disease, but asymptomatic, previous myocardial infarction, left ventricular hypertrophy, low ejection fraction, asymptomatic valvular disease, is potentially in heart failure, but not yet without symptoms. Stage C is florid heart failure. Patient with prior or current symptoms of heart failure. Stage D is refractory end-stage heart failure. Mild symptoms of arrest despite maximal medical therapy. Hospitalized, cannot be self-discharged. Therefore, prognosis is very poor in stage D. Functional classification, New York Heart Association, functional classification of heart failure. Class 1. Class 1, ordinary activity, ordinary physical activity, does not cause symptoms. It's okay. Class 2, ordinary results symptoms of heart failure. Grade class 3, marked limitation of physical activity. Less than ordinary physical activity causes symptoms. Class 4, unable to carry any physical activity without symptoms of failure and also at rest. These are the functional classification of heart failure. As we said earlier, we have two types of heart failure, chronic heart failure, systolic and diastolic. Heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. Let me emphasize this fact. Symptoms are indistinguishable. You cannot, by symptoms, tell that this person has a heart failure with preserved ejection fraction or reduced. Patients with a normal left ventricular ejection fraction who have asymptomatic left diastolic function is important because of their increased risk for future adverse cardiovascular events. Once diastolic heart failure is symptomatic, the prognosis is nearly as poor as that of symptomatic systolic heart failure. By the way, treatment of diastolic heart failure is difficult and not very rewarding. How to compare between systolic and diastolic? Systolic heart failure, large and dilated heart. Diastolic, small, LV, concentric left ventricular head. Normal or low blood pressure, systemic hypertension is the major factor in diastolic heart failure, hypertension. More common in men, it's more common in elderly women, the diastolic, and very difficult to treat, by the way. More common, low ejection fraction, normal ejection fraction, and S3 gallop, S3 gallop in systolic heart failure, S4 gallop in diastolic heart failure. Treatment well established. Treatment not well established. Emphasize once and again, the treatment of diastolic heart failure is difficult for everybody and not very rewarding. Ischemia in selected cases, ischemia is common in diastolic heart failure. Hypertension, as I've just mentioned, can cause both types. Coronary disease, reduced ejection fraction, chronic heart failure, hypertension, left ventricular artery, reserved ejection fraction, and chronic heart failure. So hypertension can lead to both types of systolic and diastolic heart failure. The Framingham criteria is very important, very popular diagnosis of heart failure. There are major criteria and minor criteria. Major. PNDs orthopnea. This is a major criteria. Increased jugular venous pressure. Bilateral rise, crepitations, crackings, whatever. Cardiomegaly, radiological. Acute pulmonary edema. S3 gallop. Hepatojugular reflux, not reflex, reflux. Minor ankle edema, night cuff. I will just tell our colleagues that anyone who sleeps on his back and cuffs is heart failure until proved otherwise, not bronchitis and antibiotics. Anyone who is lying back gets cuffed, you should be suspected to have heart failure. Dyspnea exertion, DOA, pleural effusion, hepatomegaly, tachycardia above or equal to 120, weight loss more than 4.5 in 5 days with treatment. People, some consider it minor, some consider it major. So if you admit somebody to the hospital and with fluid retention and you give him dialysis and he loses 4.5 to 5 kilos in 5 days, this is a major or minor criteria for the diagnosis of heart failure. What are the precipitating causes of worsening heart failure? Non-compliance with the diet or therapy. You have to ask your patient, is he especially salt? Is he taking this therapy? Patients are non-compliant. They don't take their therapy. They come back with relapse remission. Arrhythmias. Anemia is very common in heart failure. Systemic infection. Pulmonary embolism. This could precipitate worsening heart failure. Inappropriate drugs. Negative ion withdrawals. The common NSAIDs. These are nasty drugs, by the way. NSAIDs. They are very harmful to the heart, to the kidneys, everything. First generation CCB calcium channel blockers. Ischemia hypertension. Nobody coming back with precipitating worsening heart failure. You have to look into these factors and find out which one is the precipitating cause. What are the factors of poor prognosis in heart failure? Male gender, second diamond males, hypotension, advanced age, impaired renal function, higher NYHA, New York Heart Association class. Hyponatremia is very, very miserable. CAD and ACS, and the relays EMP. Anemia in heart failure carries very good in prognostic indicators. And it's common, by the way, anemia and heart failure. We don't know the definite therapy. In many patients, we don't know. Treatment with iron is efficient. Parenteral iron better, not oral. And there were some studies using the erythropoiesis-stimulating agents, but these are no more used because they increase the risk of venous thromboembolism. So iron is the mainstay of therapy in anemia in heart patients, in heart failure patients. CAD, ischemic heart disease, is listed as the primary cause of heart failure in approximately 60% of cases. Treatment. We start by the more difficult treatment of heart failure with preserved ejection fraction, half cough. No treatment has been shown to improve outcomes. This is definite. No treatment at all. Diuretics should be used. ACE inhibitors, ARBs, can be used. Angiotensin, converting enzyme inhibitors, and angiotensin receptor blockers. Non-dihydroargine CCP calcium channel blockers or beta blockers are beneficial by slowing the heart rate. PCI, percutaneous coronary intervention, or CABG, coronary artery bypass grafting in patients with CAD. The best primary prevention therapy of diastolic heart failure is adequate treatment of hypertension, diabetes, and coronavirus. As we have just mentioned, no treatment has been shown to improve the outcome in patients with diastolic hypertension. I want to stress this slide, very important. In younger patients, the majority of left ventricular filling in diastole occurs 70 to 90%. And the atrial contraction contributes 10 to 15, 20%. But as we age, the systolic blood pressure increases, left ventricular mass increases, the filling pressure which occurs with atrial contraction, the atrial kick, increases to 30 to 40% of ages. So why? The patient diastolic hypertension, he gets atrial fibrillation, he's rapid, puts him into acute pulmonary edema. So the mainstay why we give beta blockers or dihydropalatine gas blockers is to slow the heart rate. So slowing the heart rate and atrial fibrillation is very sinister in these patients. So the best primary prevention therapy, stress again, is adequate treatment of hypertension, diabetes, and coronary disease. This is a recent article published this month on the 10th of April in the New England Journal of Medicine, just 10 days ago, about spiral tone and Dector for the treatment of heart failure with ejection fraction. And Dector has a very important role in systolic heart failure. And they've carried this trial, just been published 10 days ago, in patients with heart failure and preserved ejection fraction. Treatment with spironolactone did not significantly reduce the incidence of the primary composite outcome of deaths from cardiovascular causes, aborted cardiac arrest, or hospitalization for the management of heart failure. So it did not meet the composite outcome of death and cardiac arrest. So spironolactone in heart failure with preserved ejection fraction did not prove itself. What's the general approach now? therapeutic approach for systolic hypertension. We determine the etiology, which is corrected or not. Look for protecting factors, which we just mentioned. We have non-pharmacological treatment, diet, salt intake, treatment of hypertension, ACE, ART, aldosterone inhibitors, we come to these again, beta blockers, diuretics, digoxins, and vasodilators are used frequently in the treatment of heart failure. Device therapy, cardiac synchronization therapy, CRTP, implantable cardiovascular ICDs, and definitely assist device. I will touch briefly some of the domain. The device therapy in heart failure needs a lecture on its own. So we have to offer it here. Dr. Yahya, الصراحة سألوا إذا ماشي I did not touch on. Recommendations for pharmacological therapy in stage C, heart failure, the most rewarding to treat. Diuretics are key treatment for both types, by the way. They don't reduce the mortality or morbidity or hospital administration. They reduce dyspnea and edema. They are very important. They are key treatment. ACE for all patients. ARBs for patients who are ACE intolerant. اللي ما بيتحملوا ACE inhibitors بنعطيهم ARBs. بس الأولوية للACE. Routine use of ACE, ARB and aldosterone is potentially harmful. Let me explain this. We don't use ACE and ARBs together, only one. And if you add an aldosterone antagonist to aldactone, you have to be careful about the blood urea and the potassium. You have to check them frequently. Creatinine, blood urea, and potassium. Use one of 3 beta blockers, evidence-based. Best therapy, carbidolol, bisoprolol, and metoprolol. These are the only 3 antibiotics, evidence-based, used in the treatment of heart failure. Not any other beta blocker. Let me emphasize this fact. Continuation. If patients are intolerant to ACE or ARBs, can use a combination of hydrazine and isosorbide dinitrate. We used to use frequently before we continue ACE. Anticoagulation, let me emphasize, not recommended in patients with heart failure in the absence of atrial fibrillation, prior thromboembolic event, or a cardioembolic source. You don't give them routinely. Long-term infusion use of inotropic therapy is not recommended, may be harmful, except as palliation. Low-dose dopamines, when it's admitted, you can be recommended to improve dialysis. And calcium channel blockers are not recommended as routine treatment. Digoxin heart failure, after the digoxin trial in 1996, we don't use them at all, but they still may be used to reduce the risk of hospitalization patients with persisting symptoms despite adequate treatment, especially those with atrial fibrillation. Still, they have a role. Everidine in heart failure. When you give beta blockers and still heart rate is high, in sinus patients with sinus lift, not in atrial fibrillation, and still you resort to everidine, which is selective inhibitor, that's a node, and reduce the risk of hospitalization patients with sinus lift definitely. Patient ejection fraction below 35, heart rate above 70, persistent symptoms despite treatment with evidence-based dose of beta blockers. You use beta blockers, and you cannot go higher because of hypotension, or still the heart rate is not controlled, you add everidine in heart failure, which is very good. CRT, as I mentioned earlier, we have authorities here who can enlarge later, can be useful in patients with sinus and limb QRS complex above 130, left bundle branch morphology and ejection fraction below 30. CRTD can be useful in patients with SR, sinus and limb QRS above 150, and irrespective of morphology of left bundle of QRS and ejection fraction below 30, not indicated if patient survival is less than 1 year. The value of atrial fibrillation is uncertain, but maybe the directive shows will tell you it could be useful sometimes. ICD recommended to reduce the risk of sudden cardiac death in patients less than ejection fraction ejection, 40 days post-myocardial infarction. That's a fact. Uncertain benefit to prolong survival in patients with high risk of non-sudden death, such as frequent exposure. ما نخش المستشفى كثير خايف عليه unless إذا في evidence of ventricular arrhythmias with hypertension and symptoms. Mechanical circulatory support, left ventricular assist device or bi-ventricular assist device for the patient with end-stage heart failure suitable for transplant. Myocardial vascular issue, we resort to CABG or percutaneous intervention in patients with heart failure and angina and viable myocardium. Patients with heart failure have angina, viable myocardium, definitely surgery has a role or percutaneous intervention. I will conclude by evidence gaps and future research directions. There are huge gaps in our knowledge about many fundamental aspects of heart failure care. The clinician must always practice the art of using the best of the guidelines. The guidelines كثير بس ما كلش واحد يعمل guidelines هاي كل مريض should pick the best of the guidelines suitable to his patient. Future research will need to focus on stem cell therapy and the new device platforms, new device therapy for heart failure. Effective treatment that reduces the progression from stage A to B is an urgent need, and thank you for listening.
Dr. Yahya, do you intend to convert AF to sinus rhythm before, during, and after mitral replacement, surgically, pharmacologically, or non-pharmacologically? Or you give anticoagulant and let it be?
In mitral valve disease, specifically or especially mitral valve stenosis, the atrium is usually big, and these patients are usually destined to atrial fibrillation. They will usually have chronic atrial fibrillation, and they will usually need anticoagulation. So probably the best policy for these patients is rate control, to control the rate. They are anticoagulated anyway. But in some patients, if the AF is recent, if the atrium is a reasonable size, and if they are symptomatic or difficult to control with their atrial fibrillation, then I think rhythm control is a reasonable target. Although it will be difficult, and it has been known radiofrequency ablation and cryoablation can be done for these patients as a curative therapy. So it really is an individual case by case for each individual patient. But the majority are destined to AF, and rate control is the way to go.
أنا سؤالين صغار للباشا حكيتها يعني. First one is coronary angiogram indicated in all patients with heart failure or not? This is first question. And second is, if you allow me, Basha, we're basically all internists, so we come almost about a suspicion of heart failure on daily basis. So when to refer? Is there anything that we can do before referring to you as a cardiologist?
First question is coronary angiography indicated?
Is it indicated in all patients whom you suspect heart failure or diagnose heart failure?
No, I think it is at least to clarify the anatomy and because there is any coronary disease, and sometimes the patient cannot differentiate between chest pain and dyspnea. There is evidence of viral myocardium and angina. As I mentioned earlier, you are very good. I personally try to evaluate coronary angiography, coronary anatomy in most patients. It's straightforward, you know. There's no hope, but most of the time, I do. Was there a question?
When we suspect, as internists, when we suspect a case of heart failure, should we refer everyone to a cardiologist, or we can do as internists something?
No, I don't think. I mean, as I said in my talk, the best primary prevention of heart failure is to treat hypertension properly and diabetes and coronary disease. You know, hypertension and ischemic heart is more than 60% contribute to heart failure. Both heart failure preserves ejection fraction and reduced hypertension. It should be treated very properly. Control hypertension and we delay the progression from stage A to B to C, that would be a great achievement. No, I don't think that to refer every case of heart failure to proper medical treatment can
Professor Lee, thank you very much indeed for your talk. I have just only one question because TAVI is not progressing very much in Jordan because of the cost, and maybe we are still waiting to see more and more results. We are very much concerned about the complications of the procedure and the evolving technologies. Now companies are producing more and more valves. Do you have a certain preference for certain valve that's coming?
At the moment, the TAVI valves, at the moment there are really just two that are available. The Edwards valve and the core valve. However, there's been an explosion in investment by companies to produce more and more of these valves. And also, the tubes that put them in, the catheters, are getting smaller and smaller. So eventually, it won't require such a big hole in the groin leading to complication. Also, people have been working very carefully on the ability to try and decrease the risk of stroke with this procedure. Because in the big trial comparing TAVI with surgery actually did better in terms of and less likely to have a stroke with a surgical aortic valve replacement than you were with a TAVI. So in some ways Scotland tried to do the same as Jordan in the fact that we held off for as long as possible to see what was going on. I think that with all these things commercially, when more companies bring out more valves, the cost will decrease. The funding model in Germany has meant that Germany performs almost as many TAVIs as they do surgical aortic valve replacements. And it's been rather uncontrolled in Germany. So there is some concern now about some of the TAVIs that have been performed in a 60-year-old person. They're coming back with the TAVI failing after 5 years. So in some ways in Jordan, I can see that it's frustrating if you don't get started. On the other hand, more information is coming out about these things the whole time, which will guide you actually more about it.
Do you give these patients aortic stenosis, statins, irrespective of the, as you said, heterogeneous, symptomatic causes? Do you think statins will decrease calcification? Do you think that statins?
Personally, I do. But there was one big trial, I think.
That's not mean that rather.
Exactly. But personally, I do. And also, I think It's important, as you were saying, for heart failure to make sure that although the patient has aortic stenosis, you're not mistreating the coronary disease, the hypertension, and other risk factors.
Thank you, Dr. Bayan. I'll stay with Dr. Bayan. I have two small questions. On the first case you presented, the attorney who died,
Yes.
I did not see serial troponins being done versus what we do in the US. When we are presented with such vague chest pain and you don't know really what's going on, we do admit the patient for observation for at least 24 hours, and we do Q4 to Q12 troponin levels. What's your standard of care there?
It's a very good question. So just on the patient I presented, I didn't present it very well because he was kept in hospital and had a 12-hour troponin which was negative. At the moment, we have to keep patients for 12 hours. But in terms of cost, it would be an awful lot better if you could do a blood test as soon as someone comes into your ED or your accident emergency department and say whether this was cardiac chest pain or not. And one of the drivers for getting this very sensitive troponin is the possibility that it might be that you could do a blood test after an hour and send someone home and not admit them to hospital, which is the expensive thing. At the moment, we are admitting people doing a 12-hour troponin. That gentleman's troponin was negative, but yeah, I would agree that that's the British standard of care.
Just a little part of this, do you look at only going up? Also, you're looking at going down, because some people come with their peak troponin and their cardiac mass is not high enough, and then it starts to drop. So you look backward and think, oh, maybe he was MI at that point. So usually, do you tend to look at the upward rise or both?
Both. And also sometimes patients who I was talking about come into hospital and they have a positive troponin, which has nothing to do with their heart. Those patients normally see the troponin might stay at the same level after 12 hours or so it's useful in that respect as well.
Sure, actually, we just had the same case, but luckily the guy did not die because actually it was ordered, but the machine did not pass and this was not done. But we caught that person in the last minute. The other last question, what do you think of induction of moderate hypothermia for TAVI and any other aortic valve and aortic aneurysm procedures? Because in Boston and some other centers, now they started to address actually putting the patient in the what we call prior death stage or pre-death stage.
I'm personally not aware of that, but we've been involved in some trials of patients who've had out-of-hospital cardiac arrest, and therapeutic hypothermia for them to prevent brain injury is very important. So I would imagine that it may be beneficial, but the amount of cerebral stunning might be a lot less that you should get from a TAVI than from a cardiac arrest.
Thank you so much.
They are using hospital death.
Yes.
I want to ask you, is there a role for coronary aspect CT and
Not in our ERs. However, my father-in-law lives in Hong Kong, and he was admitted to hospital with some chest pain. And their exclusion test was a CT coronary angiogram and CTPA. And he just returned from a flight to Australia and was picked up with a pulmonary embolism, although they suspected coronary disease. So it is being used in other parts of the world, but for us, we're not using it to exclude coronary disease.
Thank you, Dr. Yusuf, for your good lecture. There's a new study published in San Francisco Hospital revealed that sport is reduce the mortality between patients with heart failure about 10% and improve about 40% of patients with heart failure. They said that sport is very important for treatment of heart failure. Do you agree with this study? Thank you.
not aware of this, but we encourage our patients to do exercise like that. It helps heart failure.
Just that we have a cardiac rehab service, and they keep telling us that the most evidence for benefit after a heart attack is rehabilitation and exercise, so it could be extrapolated to heart failure.
At least when he exercises, he is compliant with his treatment. He reduces his weight. He doesn't add weight. I mean, it helps definitely.
Thank you, representatives. My question for Dr. Yahya about ACE inhibitors and ARBs. Is it mandatory to use in all patients, or there is selected groups to choose?
I think in patients definitely with hypertension, patients with enlarged atriums, and in patients who have evidence of left ventricular hypertrophy, ACE inhibition is important. It does reduce the recurrence of atrial fibrillation. And interestingly, statins have also been added to this. So statins, there is some evidence that they do decrease the recurrence of AFs. But if patients have recurrent AF and their blood pressure tolerates it, yes, I do keep them on ACE inhibition.
Thank you all. Thank you very much indeed. One very short question, last question. Now we are hearing about new modality of treatment of acute heart failure. It's relaxed. Maybe it's not approved yet by the FDA, but maybe it's promising. Can you tell us a little bit about that?
I know it's coming. I didn't touch on acute heart failure because I was constantly on congestion. Vaccine, it's coming up. They're telling me that next year it will be approved. I don't know whether it's very, very promising or not. We have an idea about the vaccine. Novartis. We're not promoting Novartis now.
Yeah, they claim it's a breakthrough in the treatment of heart failure for over the past 2 decades now.
It would be very important because it's a very common presentation.
All right, thank you very much indeed. We'll have a break now and we'll be coming back by 11.
بس هي جوان Thank you, sir. Thank you very much indeed. Sorry, I'm sorry. لفوا دكتور لفوا. كمان واحدة؟ لا لا. Thank you very much. باشا يوسف عمي أنا هنا أستاذي باشا علي. حبيبي الله يسلمك.
There's a sky monitor
دكتور مروان لا يحيى حبيبي الله يسلمك. وين مكتوب علي يوسف؟ ذبحتوني. انت كان لازم تتصور معنا دكتور. ثانك يو فيري ماتش. دكتور صورة جماعية كل يلا صورة جماعية.